Good evening, all, to this seventh episode of MAHAIP Case Challenge. Today, we have guest of honor, Dr. Vasant Khalatkar, sir. Today, we have two eminent teachers, Dr. Baldev Prajapati, sir, and Srinivasan, sir, as experts. Then today, we have two presenters, one Dr. Bhushan Thorat from Yavatmal, and second is Dr. Snehal Patil from Kolhapur. And today we have two teams. One is from Navi Mumbai, consisting of President Satish Sane sir and his colleagues. And second team is Dr. From team Amravati IIP, consisting of Dr. Shailesh Jaiswal and Rohan Bobde and Dr. Paskaude. So this is very nice initiative. This year we are in 7th episode of MAHAIP Case Challenge, and there are various interesting cases which are cracked always, mostly cracked by all the teams under the guidance of experts, and presenters are also doing their job perfectly. And this is a very great learning lesson for all practicing pediatricians and all PG students also. So without wasting time, I hand over mic to Dr.
And for
Deepak
teachers
Shetty ma'am
also. For
for
teachers
further
also.
proceedings.
Learning experience for teachers also.
Yes, sir. Deepa ma'am, please.
Thank you, Amol sir. So we are back with one more interesting and exciting session of MAHAIP Case Challenge. As you all know that our President Dr. Ramakant Patil sir and Dr. Amol Pawar sir are quite busy in the preparations for MAHAPEDICON, which is from tomorrow. But in spite of that, they have lived up to their commitments, and we have now today having one more exciting session of MAHAIP Case Challenge. Now, and today we are also lucky to have two experts, Dr. Srinivasan sir and Dr. Prajapati sir, and we will be eagerly waiting for to hear their words of wisdom. I requested Dr. Amol Pawar sir to welcome today's guest of honor, Dr. Vasant Khalatkar sir, and also welcome today's experts. Over to you, sir. Amol sir.
Deepa ma'am, you introduce our guest of honor, please.
Yeah. So we are honored to have today's guest of honor, Dr. Vasant Khalatkar sir. I think he needs no introduction. We know him very well. He's the consultant pediatrician neonatologist from Nagpur, and now at present also the national chairperson for pediatric infectious diseases and also the chairperson for pediatric neurology chapter. Welcome you, sir, for today's MAHAIP Case Challenge. We also are lucky to have today's experts. These are legendary personalities. Dr. Baldev Prajapati sir, he's well known for his Tuesday clinics, and where he's very consistent in that, and that's also very quite a learning platform for many of our PG students. Welcome, Dr. Baldev Prajapati sir. And our next expert is Dr. Srinivasan sir. Sir is a former director, professor, and head of Department Pediatrics, JIPMER Pondicherry, and also an adjunct professor for Department of Pediatrics for Mehta Super Specialty Hospital and PG Training Institute. And I've seen him always been there for all the PG activities, and there's a lot to learn from him. So welcome, sir, for today's session. We also have today's young presenters, talented presenters, Dr. Bhushan Thorat and Dr. Snehal Patil. Now I request our chief coordinator of, I request Dr. Ramakant Patil sir to give his wishes to today's session. Over to you, sir.
Thank you, Deepa. It is really pleasure to have this session. And one thing we always, unless something doesn't challenge you, it won't change it. And our mind never tires for learning something and never regrets and fears it. And what to say about the today's guest of honor? He has marked his footprint in both the chapters as chairperson in infectious diseases as a neurology chapter. And we want to see him as the president-elect of 2025. We have grown by learning from Dr. Amdekar sir, Dr. Srinivasan sir. These are the clinical teachers and having an excellent liaison with the modern development and modern medicine and modern investigations and all these things. What to say about Baldev Prajapati sir is the definite anything which is done very systematically. Even in cricket is said that it is a clinical game or clinical innings or clinical. And sir is the advaryu in Marathi, what we say is of clinical medicine and clinical pediatrics. And we are very lucky to have these experts for today's session. And I cannot tire in praising the coordinator for this MAHACASE challenge, Dr. Pramod Kulkarni, and ably supported by today's moderator, Dr. Deepa Firke, Naresh Taide, and other coordinators like Dr. Ravindra Sonone, Dr. Anjali Gokarnu, and Dr. Rajendra Khadke. And these are all enthusiastic people. And more important is that preparing a case, presenting it in a manner that it will be more interesting. And this job is being done by different practicing pediatricians across the state. And today we have got a young intensivist, Dr. Snehal Patil from Masai Hospital, Kolhapur. And it is very heartening to see a senior resident, Dr. Bhushan Thora from Yavatmal will be presenting case. And friends, all the board teams from Amravati by Dr. Nilesh Patskaude, Dr. Jaiswal and Dr. Rohan Bobde. Both three of these will be facing a team. Expert or guest of honor will tell which case will be faced by which team. And Navi Mumbai team ably led by Dr. Satish Shahane, Priyanka Amonkar and Ashmita Patil. I will like to thank my buddy and senior in my BJMC alma mater, BJ Medical College, Pune, Dr. Sanjay Gosavi, who happens to be a pediatrician and partner in our group hospital of pediatrics only, who is observer for today's program. And it is really a nice initiative going on and on. And I wish all the best. And I think we'll have another 3 more sessions for this year. Over to you, Deepa, for further proceedings.
Thank you, sir, for briefing regarding today's session. Now, is Dr. Amol there? Okay, I
Yes,
request.
ma'am.
Yeah. So we have already, sir, we have already introduced our experts.
Yes.
So can you just request our guest of honor to pick up the chits and we can have the first bit.
Vasant sir. Team Amravati and Team Navi Mumbai.
I hope Team Amravati and Team Navi Mumbai, all of the participants have joined.
Yes, ma'am. They are there.
Dr. Satish is there.
Yeah.
Dr. Asmita and Dr. Priyanka are there. Priyanka?
Okay.
Yes, sir. We are all here.
Dr. Vasant
Dr.
Khan,
Rohan is there. Dr. Nilesh is there. Everyone is there.
Navi Mumbai. Okay, so to the first
Thank you.
team to face the case challenge is Team Navi Mumbai. So please be prepared. I request Dr. Pramod Kulkarni sir to just brief about the way the case is to be presented and the rules of the case presentation. Over to you, sir.
Welcome you all to another interesting episode of this MAHAIP case challenge. We have got galaxy of experts and the officials of IIP and 2 new enthusiastic teams and 2 cases and 2 presenters. Without wasting any time, I'll request to go ahead with the cases. Just a humble request to the attendees, please do not comment any clues or your thinking in the chat box so that the healthy way of going ahead with clinical approach will be maintained. That's all from my side. Welcome you all and please go ahead.
Thank you, sir. So we'll move ahead with today's case. Our first presenter is Dr. Bhushan Thorat, and I can proudly say that he's one of my students. And he's a senior resident now working at Yavatmal College. So, Dr. Bhushan Thorat, are you there? Dr. Bhushan.
Yes, ma'am.
Yes, ma'am. Dr. Bhushan is here.
Good evening, ma'am. Thanks to see you.
Okay. So Dr. Bhushan Thorat will be presenting the first case, and the team will be facing the first case challenge is Dr. Priyanka Asmita Patil and Dr. Satish Shahane. These are from the one of the most enthusiastic branch from our Maharashtra, that is Team Navi Mumbai. So best wishes to you all, and I request Dr. Bhushan to start with his case. You can start screening the share.
Good evening, ma'am. I was a student of ma'am doing my DCH.
Bhushan sir, please wait for 1 minute.
Yes, sir.
Deepa ma'am,
Yes, sir.
tomorrow is Dr. Vasant Khaladkar sir's happy birthday.
Okay.
So Team MAHAIP wishes Dr. Vasant Khaladkar sir a very, very happy birthday, and we will see him as a president-elect 2024 in next few days.
So we wish him to have a happiest birthday. Yes, sir. Happy birthday to you, sir. Thank you so much.
Thank you, everyone. Really, it's a great day for me. I'm getting wish from this MAHAIP, which very enthusiastic and academic branch. And today, in presence of Dr. Srinivas, who always tell me what is the wrong in me. What is wrong with me? Always advice. Really, it's a great advice. And I can say my mentor, Dr. Baldev Prajapati sir, who never say no to any academic activity. That to be on 11th hour. Whenever I told him and 11th hour, he always say, "अरे वसंत हो जाएगा, हो जाएगा." एक बहुत बार ऐसा हुआ है कि सर को एक दिन पहले भी मैंने नागपुर कहीं बुलाया है for ID chapter, and he's always ready for it. I really want to thank. It's my great honor I got today that I got wish from you all people. I saw the enthusiasm of Amol. We were in Udaipur and he was preparing all this total program till night up to 2. मैं तो सो गया था, पर अमोल झोपायला तयार नव्हता. रमाकांत, what the enthusiasm, really great. या अशासारखी प्रेसिडेंटशिप आपण कधीच बघू शकणार नाही, मला असं वाटतं महाआयपीची मे बी. आणि आय विश ऑल द बेस्ट टू both the team from Navi Mumbai, and thank you all presenter, moderator and expert for giving their time. You know, yesterday I filled my nomination for the post of president-elect CIP 24, and you all were there. Thank you once again for your presence and witnessing my nomination form. I request all you to support my candidature and tell all your friends. I need at least today, I think 85 people are there. It should be multiplied by 100. So the victory will be there. Thank you, sir. And sorry, Prajapati sir and Srinivas sir, I talked about my election on this platform. Thank you once again. Thank you.
Thank you. Thank you, sir. Heartiest best wishes for your birthday. So we move on to our case today. I request Dr. Bhushan Thorat to start sharing his screen and present the case. Dr. Navi Mumbai team, please be ready.
Please remember the time allotted for presenting the case will be 30 minutes, and then it will be followed by discussion by our experts.
Okay.
Also, one more reminder for all the audience, please do not type any suggestions or any clues in the chat box.
Should I start?
Yes. Please go ahead.
Day 22, female neonate, 34 to 36 weeks preterm, vaginal delivery. The baby cried immediately after the birth. The birth weight was 1.9 kg and the weight on the admission was 1.6 kg. At the day of 22, the weight of baby was 1.6 kg. The patient came with a complaint of not accepting feed since 2 days with abdominal distension and not gaining weight since birth. This was the initial complaint of baby. What we expect on this generalized scenario to be what could be the possible diagnosis on just this little information on admission?
So we would like to know whether how was the feeding earlier, and since this was LB low birth weight baby for 34 to 36 weeks seems to be IUGR, what was the feeding which was initiated with? Was it breastfeeding or top feed? And how was the feeding till now? And how was the follow-up till now before arriving at this complaint right now?
Actually, baby was born at rural hospital Mahur, district Nanded. The baby was not admitted to an ICU, and baby was shifted to mother immediately after the birth, and baby was started on the breastfeed till day 22 of life. There was no top feed.
And also, what about meconium being passed?
Meconium passed till 24 hours.
Passed. Okay.
So
And-
till 2 days back, baby was absolutely all right taking feeds, and no weight was documented in between.
No weight was documented in between. There was no visit to any pediatrician or any rural hospital or that. On admission, the weight of baby was 1.6 kg, and baby came with the complaint of this not accepting feed, abdominal distension, and not gaining weight since birth.
Okay. And the feeding was adequate. The way we talk, the urine output, urine passing urine, how many times in a day, was baby sleeping well after feeding? Was that assessed for assessing the adequacy of the feeding?
We assessed the adequacy of feeding. The mother was giving the history of we are feeding the baby well. We are also feeding in the nights. The baby is passing urine adequately. But since 2 days, baby is not adequately passing the urine. Till the date 19 or 20, the baby was accepting feed well, passing urine well. And this was the sudden onsets of symptoms within 2 or 3 days, likewise.
Okay.
I will, next slide.
Yes.
Brief history. Patient was outborn. It was institutional delivery at a rural hospital, Mahur, district Nanded. Nanded is a nearby district of Yavatmal district. Family history, it was non-consanguineous marriage. There's a history of spontaneous abortion at 3 months of gestation. History of early neonatal death on the day 3 of life with complaint of multiple episodes of vomiting, not accepting feed with abdominal distension. And patient was expired at the home. The mother was having a spontaneous abortion at 3 months of age, and there was a death of his one of sibling at the day 3 of life. With the same complaint, not expecting feed, and the patient was expired at home, and patient was brought dead at RH Mahur. There was no admission history or any history. Patient was brought dead, and that's why the cause of that death in the sibling was not known. Just there was the same history of multiple episodes of vomiting, not accepting feed, with abdominal distension. From this history, what can we expect the diseases or any elements in the neonate that sibling death or abortion?
So we have to start thinking about metabolic disorders over here.
It can be one of the possibility. It can be one of the possibilities. Since the baby was brought dead at RH Mahur, and no history was there was no any history.
Even the previous babies were low birth weight. The previous first one baby which died on the 3rd day of life.
That baby was also low birth weight, but weight was not actually counted by the relatives. But they are saying like it was like around 2 kg.
And metabolic screening was not done. Neonatal screening.
Metabolic screening was not done because the patient was brought dead at the RH Mahur. There was not even a single CB or CBC was there. Metabolic or we will move to next slide. There's a history of spontaneous abortion in the paternal uncle side also, but proper documentation was not there. Not much information about that. But just they were saying there's a history of spontaneous abortion in the paternal uncle side. Can also accounts to yes, sir.
So this is Gravida 3 with first spontaneous abortion, second neonatal death. And this is the
Yes.
third graph. Okay.
Yes, ma'am. Yes, ma'am.
Uh,
Should I move to next slide or can we discuss more? Yes, sir. Yes, sir.
You can go ahead, Dr. Bhushan.
Okay, ma'am. Course in NICU. On examination, the baby was euthermic. Heart rate was 146 per minute. Respiratory rate was 42 per minute. SpO2 was 98% on room air. There was pallor is present. Frontal bossing is present. There was no cyanosis, icterus or edema seen. System examination, CVS S1, S2 present, no murmur. RS air entry bilateral equal. Tritone activity was normal. So on presentation, there was just generalized examination was pallor was present and frontal bossing was present. We will shift to next slide.
so what about abdominal distension? So was it
Just
generalized?
I have added on that next slide because that was the main finding. So I have added on the next slide.
Okay.
Per abdominal examination, it was soft, non-tender. Liver was 6 centimeter, palpable below costal margin. It was non-tender, firm. It moves with the respiration. And the spleen was 5 centimeter, palpable below subcostal margin, and moves with the respiration. So there was a huge hepatosplenomegaly. The liver is a 6 centimeter and spleen is a 5 centimeter. It was unusual presentation in the neonate to present like splenomegaly with 5 centimeter. With the baby is having 1.6 kg weight and spleen of 5 centimeter. What can the DDs of the splenomegaly in the neonate? Can we discuss about this?
So we can think one is of torch infections can present like this.
Torch
Yeah.
infection can present like the splenomegaly.
Even congenital tuberculosis can present like this. Then we have to think of storage disorders, which can present with the hepatosplenomegaly.
Yes, it can be.
So CNS involvement is not there. Otherwise, this cry tone activity is normal. And
Tritone activity was normal. There was no neuro.
And the abdomen distension to the child is passing stools. And distension it was gaseous or it was just something which the doctors noticed and it was actually organomegaly and not distension.
It is actually organomegaly. It is not actually a distension. Bowel sound was present. Patient was passing stool also.
Yeah.
And there is no neural symptoms to the patient.
So we have to think of metabolic disorders, including storage disorders, torch infections.
Any other?
Not on the list, but we have to also keep hemolysis in the mind because there is pallor and hepatosplenomegaly.
Yes, there was a pallor and frontal bossing also there.
Yeah.
We can
So,
also...
yes, so hemolysis should be kept in the mind because there is pallor, frontal bossing. We would rather call it splenohepatomegaly because spleen is quite large for this age.
Yes. Can we think of the more DDs of the hematological system in this patient rather than viruses and
right. One thing is that there are spontaneous abortion in paternal uncle. So some hereditary cause should be thought of.
It can be.
One of the autosomal recessive condition which can be transmitted.
Okay.
Could be hereditary.
Next slide.
Yes.
Prajapati sir wanted to say something, sir. You are raising your hand.
Yeah, I think should I tell something?
Yes,
Sir,
sir. Yes, sir.
you can have your comments, expert comments.
Yes.
Yeah.
I think for general thinking, I am bringing this point specifically probably for the students that whenever we get these type of history or story that the baby was even preterm and is small for date, try to think the regions at the three sides. any problem with the mother, any abnormality with this placenta, or really baby is having some issue. I think already antenatal history, everything must have checked for diabetes, RH incompatibility, maternal infections. I hope that it is to be checked, which can also affect the babies in this way. I think placental involvement would be in different ways, so which is less likely. Then third aspect is something is wrong with the baby. And with the reference to the one spontaneous abortion and one early neonatal deaths, if we try to focus, that means something is going on, which is responsible for these abortions and even the early neonatal deaths. Then what we can consider? Suppose if the first thing, at least we should check the RH, because it can also cause this type of the problem of even hemolysis, hepatosplenomegaly, even significant pallor. But I think it may be obvious with the history and even the blood checking. But still, other even hemolytic things should be kept in mind.
Can I add something, sir?
If we focus for the infection, then which infections? Already torch, yes, but among the torch even, probably congenital syphilis should be kept in mind in this type of story, where abortions and early deaths have been taken. It can also present with the hepatosplenomegaly, even these pallor, frontal bossing, and all other things. And of course, later on, we can keep in mind metabolic disorders. So I think that maybe should be our thought process.
I want to ask one question. Can I ask?
Yes, sir, please.
Yeah, I want to know whether skin, anything abnormal seen in the skin. Skin is the largest organ in a child, especially with this type of history. Any skin manifestations were there or not? I just want to know.
Skin was normal, sir. There was no any erythematous rash.
Fine. Yeah.
Since icterus was not there, hemolytic.
No peeling, nothing. Okay, fine. No evidence of
even icterus to this patient.
blueberry
hemolytic also we can sort of rule out because there was no icterus.
Yeah.
Okay. You can go ahead.
Yes.
Yeah.
The patient was received in ICU with complaint of pallor, hepatosplenomegaly. The CBC was done. The hemoglobin was 7.3 grams. The WBC was 27.8 thousand. Lymphocytes was 56%. Granulocytes was 31%. And platelet count was 1,000. There is a anemia, there is a leukocytosis, and there is a thrombocytopenia on the CBC. After this, the PTNR was sent in suspected of DIC or any sepsis. The PTNR was sent. Prothrombin time was 13 seconds. INR was 1.1. The PTNR was also normal. We have seen other investigation also. The renal function test, urea was 12, creat 0.4, bilirubin was 1.8, direct bilirubin was 0.8, sodium was 136, potassium was 4.3, and CRP was 8 milligram. After these reports, what should be suspect in the patient after seeing this all the report? We should focus on just CBC first, and PTNR was normal. First thing come to our mind was the sepsis. Other than that, but to think of sepsis, the CRP was not increased to that level, and PTNR was also not deranged. What others can think on this CBC? Can we? Yes, sir.
Could I speak?
Yes, sir.
Okay. I think it is a little bit obvious from even the examination finding pallor and hepatosplenomegaly.
Yes.
Certainly, whatever the etiology, but hemolysis is there. And anemia is the attention drawing. Even if you go for the CBC, definitely 7.3 gram hemoglobin for this age is certainly severe anemia. It's not just anemia.
Yes.
I think regarding WBC count, we should be cautious. I'm sure that this must have been done by the cell counter. And in a case of hemolysis, even these premature RBCs, normoblast or something with the nucleus, that might have been interpreted as this, even the WBC count. That is quite common mistake, and therefore, I think the pathologist should check even on the peripheral sphere examination and even by the manual method. Because this is very common that with the hemolysis, the nucleated RBCs are considered by the cell counter as the WBC. So whether it is really erroneous WBC count is raised or in the true sense leukocytosis.
Yes, sir, we have sent a repeat sample on the cell cultures. We have sent CBC cultures, sir. The report was almost same, around 28,000 WBC count, and HB was also around 7, and platelet count is around also 1 lakh. It was another
and platelets is at lower side. So
platelet is on the lower side.
Yeah. I think another thing, even the bilirubin is marginally raised.
Sir, Prajapati, sir.
Indirect varieties, so hemolysis is.
Dr. Mahesh wants to say something.
We can say.
Just one kind of a pattern I just want to remind. This is a case challenge wherein presenter is presenting to 3, and experts, we usually take the comments at the end of the case. We want the panelist to crack the case, and then you're noting down the suggestions on the way, because I know Dr. Prajapati can crack any case that comes to me very well. Okay, so basically here the challenge is to the team of pediatrician from a certain district. You note down your point, and at the end you can, or in between, suppose they are stuck, then please don't misunderstand me.
No, not at all.
The concept and pattern is that we have really renowned experts. We are very happy to have them, but we want your kind of wisdom, maybe at the end, how they could have gone. In between, if they are stuck, please intervene.
Certainly, we understand Dr. Mahesh always in the right way.
Dr. Prajapati being a great teacher, he gets.
Dr. Prajapati can take any case. I don't think there is anything left to be.
Sorry. I think we were not aware of this point.
Yes, sir. Please.
Thank you, sir.
Bhushan, Dr. Bhushan, sorry for the interruption. Actually, I just joined because of my internet connection was poor. So can you just summarize the points in the from the beginning?
I can quickly go through all the slides.
Just brief history.
Few slides have been shown.
Yeah, Bhushan, just brief history.
Yeah.
Initial presenting history.
No, only few slides. They can see all the
slides. Just summarize, Dr. Bhushan, so that we
Yes,
can.
sir, I will summarize first. It was, sir, day 22 female neonate. It was 34 to 36 weeks preterm. It was vaginal delivery. Baby cried immediately after birth. The birth weight was 1.9 kg and weight on admission was 1.6 kg. There is a poor weight gain. Patient came with complaint of not accepting feed since 2 days, abdominal distension, and not gaining weight since birth. Okay, sir.
Yes.
Moving to next slide. It was outbound delivery at a rural hospital, Mahur, Nanded district. Family history is non-consanguineous marriage. There is significant history. There is a history of spontaneous abortion at 3 months of gestation. And there is a history of sibling death, neonatal death on day 3 of life, the multiple episodes of vomiting, not accepting feed with abdominal distension. Patient is expired at the home and it was brought dead at the RH Nanded. So we couldn't initiate the proper history. There was not even a single CBC of that patient. So there is on day 3, there is a sibling death. Sir. And there is also history of spontaneous abortion in the paternal uncle side. I'm moving to next slide, sir. Course on NICU, the baby was euthermic, heart rate was 146 per minute, respiratory rate was 42 per minute, saturation was 98% on room air. There is a pallor is present, sir. There is a frontal bossing. There is no cyanosis, icterus or edema. CVS examination is normal, RS examination is normal, CNS examination is also normal. On per abdominal examination, it was soft, non-tender. Liver is 6 centimeter, sir. 6 centimeter palpable below costal margin, and spleen is a 5 centimeter palpable below subcostal margin. Patient was received in an ICU with a complaint of pallor and hepatosplenomegaly, and CBC was done, sir. The hemoglobin was 7.3 grams. WBC count was 27.8 thousand. Platelet was 110,000. So there is anemia, leukocytosis, and thrombocytopenia in the CBC. So we suspect of sepsis the first. We sent PTNR. The PTNR was normal. PT was 13 second. INR was 1.1. Rest other examination was also normal. Renal function test was normal, sir. Serum bilirubin was also normal. CRP was 8 milligram.
Any procalcitonin was there?
Yes, sir.
Procalcitonin?
Sir, this patient was in sir our NICU at SVN GMC. So the facility of
Okay,
procalcitonin
okay.
not in it.
No problem. Any LDH or something like hemolysis for hemolysis, LDH?
The facility of LDH was not there in sir SVN GMC. So we couldn't
Okay.
send this investigation.
Can we know if there is any maternal, any significant history, antenatal, or any history of blood transfusions in the family? Anything else in the rest of the history significant?
As such, there was no history of blood transfusion in the mother.
Mother was healthy.
Mother was healthy, sir.
We have to look for all, suppose, for example, HIV, we have to rule out torch infections. So HIV, tuberculosis, nothing as such in the mother.
Nothing. Antenatal history was absolutely normal.
And no history of blood transfusion.
There is no clue of any congenital infection or that. Mother was absolutely normal, absolutely fit and healthy.
And no blood transfusion in the family.
There's no history of blood transfusion as such.
We can think of even sickle cell or maybe HS, if at all, given the anemia and hepatosplenomegaly. So, but we have to look for any, with the, I think paternal side there was another death, but not blood transfusions.
No blood transfusion. The details of that death was not, we could not document that the details of that.
So in this child, we would still keep sepsis in mind, though first CRP is 8. And then hemolysis is the second possibility, depending on the history and investigation so far. And storage disorder, metabolic disorders to be followed.
We also keep all these differential diagnoses as you are thinking, ma'am.
Given, I mean, such a huge hepatosplenomegaly would not be there in a usual septic child. We can, and CRP is negative, so sepsis is again unlikely. With this history also of previous sibling deaths, it looks like something which is hereditary. And we have to think of storage disorders also, so Gaucher's and
yes, congenital Gaucher can also be present.
So in bone marrow infiltrative disorders also we can think of, but like for example malignancies. But then there is a family history of previous siblings also affected. So then CML or maybe leukemias may not so likely that way unless.
So we'll keep as a first as a
you can think
sepsis.
of any leukemia which present earlier.
Yeah, no, this is very unlikely to present in first 1 month of life. So first 1 month we keep up 3 possibility. One is infection, that is second is metabolic. Yeah.
I want one clarification. Can I give me the clarification? Because of poor this thing and the child died and then subsequently abortion. So naturally, VDR would have been done. So they would have tested for congenital syphilis because of the bad history. It was done in this pregnancy?
It was not done, sir. No, it was not. It was a rural product.
Usually, whenever there is a poor this thing, they usually do it. Yeah. Thank you.
I'm moving to next slide. Should I?
Yes.
Yes.
Before moving to next slide will give us clue and diagnosis. I'm before that, anyone can comment. I just flashed the slide. Anyone can read that because next slide will give a diagnosis. Should I open the next slide?
Yeah, we discussed that we would like. Actually, sir only told you would like to do a peripheral smear to look into the.
We have done peripheral smear for that first. We have the peripheral smear finding. Actually, peripheral smear was done by the associate professor in our pathology department, very senior pathologist, and he has given this report. Because we have our one of the resident has done, and he also called to the senior pathologist, and he has done the peripheral smear examination, and it reveals the diagnosis also. Ever moving to next slide, it will give our diagnosis. Peripheral smear was done. It was suggestive of normocytic to microcytic RBCs. Few microcytes was there. WBC count, the total leukocyte count was 28,000. The band forms are 7%. Blast and blast-like cells were 2%. The myelocytes are 6%. Metamyelocytes are 3%. What is the diagnosis then?
Aplastic leukemia.
There's an immature cell series, basically. So this kind of like is a pouring of RBC. Yeah. There has to be some marrow infiltration.
Can you comment on the conditions which show the metamyelocytes and myelocytes? Because the blast cells are only 2%.
Yeah.
Consider on the myelocyte, these conditions shows the myelocyte and metamyelocytes.
Yeah, something that is like immature things are pouring out of in the blood. So some kind of either I would say hemolysis. There is
EBV, whether other things. So any we would have a shift to left in any infection, bacterial infection, or apart from that.
I'll give one clue. We also sent blood culture. Blood culture was negative. The sepsis was ruled out.
But there has to be some infiltration of the like reticuloendothelial system, which is coming out of the marrow, basically.
Yes.
Yeah. So that infiltration has to be there.
Reticuloendothelial system is involved, and reticuloendothelial
Yeah.
system is involved. You just have to think on the diagnosis. Consider the myelocyte and metamyelocytes. It is the disease of metamyelocytes. Just we have to figure out which disease it is, which leukemia it is.
So it is metamyelocytes, and they say, there is a maturation arrest. Obviously, it's not becoming this thing. So
age is just 22 days.
Because this child has no pancytopenia. It's more of a only hemoglobin is involved, more of a immature RBCs. So erythrocyte cell lines are involved actually. So this erythrocyte cell line will be either in cases of like infective, what we get is a malaria, or in cases of sepsis also we can get, and some cases of like that site disorders, RBC cells, like pure cell aplasia, or sometimes like congenital blastomia, or where there is a hepatosplenomegaly can be possible because of the storage basically.
Pure red cell aplasia can we also consider that, but the differential diagnosis is another, sir. Can we again think upon any other diagnosis? Next slide will give a diagnosis because it was. Should I move to next slide?
I think Priyanka, any pure cell or any red cells pathology where it can affect the neonatal age group. Like only thing is one we get diamond black fan and all, but usually they will present little late. So early will be definitely pure red cell aplasia, but I don't know about how the spleen and liver in that.
Here there is a leukocyte involvement also. Mainly, besides leukemia, anemia, there is definitely a maturation arrest of WBCs and yes.
You can move ahead.
I'm going two options which can be reveal the diagnosis. It is ALL or JMML.
Leukemia.
It can be is ALL present so early or JMML can present this early. Juvenile myelomonocytic leukemia or ALL.
ALL will have some time because anyways what we can see ALL in the neonatal age group is more after 3 months of life. Juvenile myelomonocytic leukemia can present, but this like it's very rare.
Okay. I'm moving to next slide. It will reveal diagnosis. Working diagnosis: the 34 to 36 weeks preterm with a pallor, with abdominal distension, with hepatosplenomegaly, with not accepting feed. The PS suggestive of myelocytes 6%, metamyelocytes 3%, blast and blast-like cell 2%. It's suggestive of juvenile myelomonocytic leukemia. And this patient was referred to sir higher center because at SVN GMC there was no facility to treat and diagnose for furthermore in the patient. Patient was shifted to GMC Nagpur, and then from the GMC Nagpur patient was shifted to Mumbai. So we couldn't retrieve the information from the relatives what the another diagnosis. Patient was referred to Mumbai then. But after the talking with the senior pathologist, was associate professor, he said that it is a juvenile myelomonocytic leukemia. Here is the slide, sir. Here is the slide.
Okay, basically that means there is a marrow infiltration only because of some factor. That's
Yes.
why the reticular infiltration is involved. Basically, the pathology is going to be same, but the causes may be different one.
Yes, yes. Actually, during GMC Nagpur, I have worked in the hemato-oncology department during my residency. So I have seen almost 2 cases in that period. So during my senior residency in Yavatmal, though, I think of this case within the 2 minutes when I saw this patient in my evening rounds. I have ordered my junior resident to send PS and kindly look for the myelocyte metamyelocytes. During the morning
This
round,
is metamyelocytic leukemia or metamyelomonocytic leukemia?
myelomonocytic leukemia, sir.
Yeah. Because I was thinking of metamyelocytic because there's the maturation rest leukemia of that cell.
It was a myelomonocytic.
Monocytes are not increased in that, So I was wondering only monocytes you haven't mentioned that they have increased, but it's only mainly myelomonocytic. Okay.
It is myelomonocytic leukemia, sir.
Actually, it was a very good case. Even while we were discussing, we thought of TORCH, we thought of other infections. Malignancy was the last thing which came. It came to our mind, but probably last and not the first thing we would have thought of. So good case. But
Yes.
of course, hepatosplenomegaly, we have to think of infiltrative diseases as well.
Yes.
Very good case, Dr. Bhushan. And great that you have diagnosed it within a few days, I would say. That's quite a challenging case here.
Yes,
I would now request Dr. Prajapati sir, because we are just eager to hear his analysis, because he does have a very detailed analysis of all the cases. So, sir, what are your views regarding this case?
I think I have one question to Dr. Bhushan. The history of these abortions and these neonatal deaths are related to this condition.
It can be, sir, some few cases. There is a 1.2 million cases of incidence of JML worldwide, sir, but not common in India. It can present even earlier, sir. But in the previous sibling, it can present at birth also. And this baby thrive up to day 22 with this condition. It might be in that sibling also.
Is there any explanation that by which mechanism the other siblings are affected, leading to the abortions or deaths?
Spontaneous abortion can occur in JMML. There are certain studies also there. And sir, in the previous sibling deaths, sir, there was same complaint, sir, not accepting feed. And also there is a
genetics of the gene is involved. Actually, other children might have been involved. But if there is no specific gene identified for this leukemia, then of course you cannot say the previous deaths were due to this.
You know why I'm asking this question? I think as a general pediatricians, if we go for the common thinking, that whenever there is a history of these multiple abortions or the deaths,
yes, sir,
then what factors will check? During which I talked that with the mother, either the diabetes mellitus or even the infections with the baby in the form of congenital syphilis, or at least even the storage disorders. Yes, the history can be there with the siblings and others. But I think with the reference to this, if we try to explain the link that having this diagnosis with this child, how we'll try to explain these previous abortions and neonatal deaths. I think that remains unanswered, I think. Just for the sake of, I will say, the general pediatricians like me and for the students,
yes.
Whenever these kind of presentation is there, what common conditions we should keep in mind? I think just I will enumerate. which will be useful at least in the future for similar cases. At least
Saving
in our
the
center,
scenario of the first
at least in-
first
at least-
diagnosis. First, we think about the metabolic diseases, sir, storage diseases, congenital infection. This was our line of thinking.
yeah.
First, we think of, sir, sepsis, then storage disorder, then congenital infection like cytomegalovirus, toxoplasma, epistin virus. It can also be present in the congenital HLH in the splenomegaly. You also think of that, but our line of thinking also of the reticular endothelial system. So also we send the investigation. We diagnose this case like this.
That's why I will say that I may start simply from the malaria. And it has been found even at least 2 occasions I remember that we discuss everything in such maybe about 2-3 months old child and turn out to the malaria in the bone marrow, not even the peripheral smear examination. Long back, but so I think that we should keep in mind. Second, of course, the RH income should always be checked. Even third, this type of presentation with this bone marrow involvement, even the diamond black fan, and which can also present with the hepatosplenomegaly, pancytopenia, infections. So that also we'll have to keep in mind. And of course, the storage disorder, as already you discussed, and even the malignancy, we may keep at the last, as I think Madam one of this discussant very rightly said that malignancy we may keep at the last. But the only point which again, if I sensitize all of us to think that how we'll be able to explain the previous abortions and deaths, that remains unanswered. Thank you very much.
Yes.
Yes. Definitely a very good carry-over message that yes, we should think of commoner diagnosis first. Though this has come as malignancy, we should always think of the more common diseases. And I think that is very well explained by Dr. Prajapati sir. My request to Dr. Srinivasan sir. So you were asking regarding some skin manifestation. So can you just?
Yeah, there is a definite genetic predisposition.
Yeah.
Just now I was just going through to find out. They have specifically mentioned genes are involved. Genomic landscape of juvenile myelomonocytic leukemia, congenital myeloma. So unless there is a gene involved, you cannot explain the previous 2 conditions. No, children die.
Yes.
So because most of the things, just like parental chromosome is involved, nowadays genetic this thing is there because 2 children dying earlier. Really, we have to think of that. Of course, I thought of myelomonocytic leukemia. So because of the increase in cells and severe pallor and frontal bossing. But of course, this I'm sure previously gene studies wouldn't have been done. But now genes have been integrated in this thing. Just I went to as we are discussing, Dr. Prajapati was discussing, I thought, what is the genetic component? There was a definite genetic component is there. Yeah. So it's important that for the next pregnancy, the mother should be investigated. Yeah. The fish technique should be adopted to find out. Yeah.
So there is a genetic association also like Down syndrome, trisomy 8, trisomy 21, Noonan syndrome can also present with JMML, sir. It can be there.
Yeah.
So definitely that explains the previous sibling's death probably.
Yes.
Because of the genetic involvement. Yes. Okay, so that was a very good case. Thank you,
Very
Doctor.
rare condition, but we have this thing. Every child has a message to give us.
We should always remember that we should always start suspecting common cases.
Especially when there is a marked leukocytosis in one single line, we have to think of that possibility of leukemia.
Yes. Okay, thank you, Dr. Bhushan, for that excellent presentation, and also the team Navi Mumbai for giving a very good approach towards this case. Now I hand over the further session to Dr. Taide. Dr. Taide, are you there?
Again,
okay,
very interesting case by Dr. Bhushan. And now we have our second presenter, Dr. Snehal Killedar Patil, who is a pediatric intensivist at Masai Hospital, Kolhapur. And Madam is going to present the case to Team Amravati which consists of my friend Dr. Shailesh Jaiswal, Dr. Rohan Bobde, and Dr. Nilesh Patkode. I request Patil Madam to please start the case.
Sure, sir. I'll thank such a huge platform and thank you, Kulkarni sir, for guiding me. I'll start sharing my screen. Should I start, sir?
Yes, you can go ahead.
You can start. Yeah.
This is 13-year-old girl, child, born of third-degree consanguineous marriage, third by birth order, came with chief complaints of abdominal pain, nausea, vomiting, and fever since 1 week. So, what is your early thoughts of only this seeing this history? When is system?
Hello, madam. I thought Team Amravati is not unmuted. They asked.
Yes, sir. Given permission. Given permission.
Okay. Okay.
Rohan sir, you can unmute yourself.
Dr. Snehal, probably
Yeah,
your
thank you, ma'am.
connection is
Yes, sir.
poor,
Thank you.
so your voice is breaking. So if you have any problems with your internet, you can just switch off your video. Okay, because your voice is slightly breaking.
Okay, okay, ma'am.
Yeah. Okay, so
Okay.
Amravati, Team Amravati, are you there?
Yes, ma'am.
Yes.
Yeah.
Yeah.
Hello.
Hello. So, what are your early thoughts of this history?
Yes, this can be anything from infection, GI infection, gastritis, or n number of infections can cause such things. So we'll see for what was the other further history, what was the presenting complaints, how was the child.
Okay. I'll move forward. In this, abdominal pain was sudden in onset, diffuse, non-radiating, severe in nature, no aggravating and relieving factors. This vomiting was associated with nausea, non-projectile, containing food particle, not containing blood, bile, 2 to 3 episodes per day. Fever was high-grade, continuous, not associated with chills and rigors, subsiding with medicine. And she was admitted elsewhere for 5 days with these complaints. So, any additional information you want after this?
Sugar level, blood sugar level, and urine ketone level. Blood sugar level.
In any history.
Okay, history. Okay.
So, what are your thoughts on the history and examination? What are your
Presenting complaint is with abdominal pain, vomiting, nausea, and fever is also there.
Yes.
So first thing we should rule out is it an infective cause? Whereas fever was high grade fever is there, and it is and it's continuous since last 5 to 8 days, I think. So first thing that we have to rule out is infection. The other thing that I want to know is there any history of travel? Is there any history of
outside food?
Yeah, outside food in such cases. There is
Animal contact.
Okay. Okay. Okay, I'll just go next slide. There is no history of loose motions, blood in stool or passing worms, no history of urinary complaints, recurrent UTI, no history of colicky pain, no history of traveling or outside food intake, no history of cough cold, or no history of rash. So any further information you need after this?
Dr. Snehal, may I make one comment, please?
Yes, sir.
I think, can you go to the previous slide? What I want, for the sake of, I think, our understanding, that whenever the multiple complaints, please put in a proper order, chronology, that what was the first complaint? Whether all the 4 symptoms started simultaneously, I think, which is not common. What was the first complaint? What was the second? And I'm sure that addition of these symptoms will give you some pathophysiology to understand. if you have the information, please provide. Thank you very much.
Okay. Actually, this was admitted 5 days elsewhere, but they told ki everything was started together only, like that. That this was a history they gave actually, sir. It's nothing like 1 second like that. They told everything was together only. For that matter, they were admitted elsewhere.
Okay.
Okay, sir. Any other information you need after this?
Any similar complaints in other family members?
Yeah. Yeah, I'll just show you. There's a past history of the similar complaints 1 month back, and she was relieved with oral medicines and treated, which is treated on OPD basis outside. Otherwise, personal history, she had to attend menarche with good diet, good sleep. Family history knows history of similar complaints in the family. Birth history was insignificant, developmentally normal child with immunization, good immunization. So anything with this history, would you like to discuss any differential diagnosis?
Abdominal infection. Any history of sickle cell disease in the family?
No, there is no history.
Would they like to know a little more about the abdominal pain? Because abdominal pain is a vague term. Abdomen is a big won't like to know about the area where the abdominal pain
Which
has been.
yes.
Yeah, it's very important, isn't it?
Yeah, the area which is
Yeah,
there
please ask that particular question. Whether there was any specific area was mentioned or it's a diffuse abdominal pain. That may give a little more light to a possibility.
Okay. She was just telling diffuse abdominal pain, sir. She was not at all localizing. Whenever you touch, she was wincing in a
Very
pain.
important information. Yeah.
Is there any signs of any ascites or
Yeah, I'll just show in the next slide, sir. In examinations. So in general examination, she was conscious oriented. She was a favorite time of admission with height of 50th percentile. Weight is around 30th percentile. Heart rate, it was 96 per minute with peripheral pulses well palpable. BP is in the 15th percentile. Respiratory rate is around 30 per minute with saturation 99 on room air. She was pallor, ectric, with no edema, clubbing, or lymphadenopathy. Skin, joint, oral examination was normal. So any clinical interpretation you want to do with this general examination?
there is an undernourished child with the pallor and icterus present.
Acute GI infection.
So rest vitals are looking normal. There is no any systemic involvement to be seen. But undernourishment is one thing that we'll have to check the reason for that, and the reason for icterus also.
Yeah. So okay, sir. I'll go to systemic examination.
With pallor icterus, would they like to consider any specific
Any organomegaly? Any organomegaly?
Yeah, that is there, sir. I'll just go to systemic examination. Okay. So on per abdomen, she had distension, umbilicus central with tenderness all over abdomen, with liver palpable around soft 3 centimeter below costal margin. Liver span is around 12 centimeters. Spleen was not palpable. There was no shifting dullness. CVS S1 S2 normal with no murmur. RS air entry equal on both sides with few crackles. And CNS wise she was conscious oriented.
So we are localizing the at least system to GI system here.
Yes.
As hepatomegaly is there, persistent vomiting, and similar history 1 month back. Any findings suggestive of hepatitis?
Icterus is there.
Icterus is there.
Icterus is there.
So this could be
Bacterial infection, viral infection.
yeah, viral hepatitis or any bacterial infection causing
Involving liver.
yeah, involving liver.
Yes, sir. So you want any for what you want further, sir? Any informations apart from after that?
So liver and leptospirosis kind of something.
Yeah, I will like to investigate this further.
Yes.
And that
Okay.
will
So
require
these are
CBC blood investigations.
these are the investigations done outside, sir, when she was admitted there. So what are your interpretation on these investigations?
For 13-year-old, there is definitely anemia.
Hmm.
Counts are persistently on lower side.
Leukopenia and thrombocytopenia
Hmm.
with hepatitis.
Hmm.
Where's the SGOT? SGOT.
Dengue negative.
Yeah, dengue is negative. So this looks like an viral hepatitis picture in first look.
Very low.
Bilirubin is not significantly
It could
raised.
be a dengue-like illness.
Okay.
I think that viral hepatitis will cause diffuse pain abdomen or only over the liver.
She was
You must have seen so many cases of hepatitis, but how often it is presenting with diffuse abdominal pain?
Hmm.
It is usually localized to the liver
Hmm.
only. But I am asking the participants, or I am asking them to think a little more.
Sure,
This
sir.
looks like an viral illness
Diffuse abdominal.
with diffuse abdominal pain.
Dengue-like illness
Yeah,
or
some-
viral hepatitis.
Can we know whether it's hepatotrophic or non-hepatotrophic virus?
Child had diarrheal symptom also. Hepatitis usually doesn't cause
Diarrhea.
diarrhea.
Yeah.
So you must
There is
think
no-
of a wider perspective, isn't it?
There is no history of loose motion.
No loose motions.
A clue of generalized pain in abdomen rather than
Platelets are not mentioned. What are the
It was
platelets?
Yes, sir.
Platelets are not mentioned. What was regarding platelets count?
139. Low.
Platelets are
83,000.
dropping. It is dropping platelets.
Hmm.
So it looks like a dengue-like illness to start with.
What is hematocrit?
It was like appropriate, sir, around 30, 33.
Okay.
Like that. It was not like higher side. Okay. Any investigation you like outside done? Actually, I'll show this. He has done USG outside, which shows hepatomegaly with gallbladder thickness and minimal ascites. This was done also outside. Okay. So this was the treatment given outside. They started piperacillin-tazobactam, IV fluid symptomatic treatment given. She was not treated. She was treated with this, but she was not improving. So they shifted us. So while shifting, what all the investigations would you do on in setup, sir? Yes, sir.
Yes. We'll see. We will do the PS examination to look for platelet counts, and if there is anything we can see in abnormal cells are there. I'd like to see
USG for appendicitis.
Okay. Okay, I'll just show the report. This was the investigations what in our setup. What is your interpretation and what else you want to do, sir?
Your WBC count, you say it has come down.
Yeah, WBC is persistently low. Platelets
Yeah.
are also lower.
So
This
think of
time
a little
bilirubin,
more.
this time
think-
bilirubin is increasing, looking like pancytopenia now.
PS for MP and malarial antigen.
Yeah.
Okay. Okay, sir.
Apart
this
from
is-
infective, will you consider anything else beyond the infective? I am trying to give you a clue, especially with the WBCs involved.
Yes, sir. Bone marrow involvement can
Bone
be
marrow
bone
involvement.
marrow.
So could it be autoimmune type of hepatitis rather than
Yeah.
infective hepatitis? Will you consider that possibility?
Could be
So, I
possible.
mean,
There
there
is
is
a previous
past
history also.
history.
Previous history is there.
Okay. Any other investigations? You
May I
would
make
like?
a comment?
Yes, sir.
Viral markers, hepatitis A antibody, E antibody,
Yeah. Okay, sir. I'll just show.
and peripheral smear.
Reticon was 2.1, peripheral smear normocytic thermochromic with WBC, no abnormal cells with neutrophil 75%, lymphocyte 18%. CRP was negative, hepatitis IgM A negative, hepatitis IgM E negative with amylase lipase on higher side, sir.
So acute pancreatitis.
This could be acute pancreatitis as serum amylase and lipase are rising.
Yes.
Leading to hepatitis.
Yeah. That is leading to hepatitis.
Okay. Anything else you want to do now?
CT abdomen.
Okay, before that, blood investigations.
Lipid profile करना है.
Yeah. Lipid profile, RBS and sugar levels.
Liver or pancreas में
HbA1c.
Any specific, no, for systemic lupus erythematosus or some other autoimmune markers you would like to look for? I'm just asking you. Because it doesn't look like, no, quarter type of hepatitis.
hepatitis का liver or any
ANA negative.
नहीं.
ANA.
I'll just go further. These are the investigations which are negative. Just say dengue as a negative, malaria antigen, well Felix brucella, everything was negative. So any basic investigations you would like to add?
What is the blood sugar level? Blood sugar level
It was normal. It was normal. It was not much significant. I think it's 120, 130.
ANA.
Before that, you want to do anything else? Because I have few slides.
Yeah, I have.
And why ANA, sir?
For SLE.
Persistent immunology.
Okay, so you haven't asked X-ray. So this is the X-ray on admission.
Okay.
So what is the interpretation now?
Bilateral infiltrates in the lungs.
Yeah. So actually, yes, even systemic examination, she was 13-year-old with 30 rates. She was tachypneic on admission.
Chronic malnutrition.
Yeah. So anything else now you want to do?
Montas test.
GL for AFB.
Monto.
Sibinat.
Okay. Anything else?
ESR.
Okay. Okay. Anything else? What else? Actually, what we have done, that's what actually I'm asking. ESR was 35. I'll just tell you.
Okay.
What is the probable working diagnosis here?
Yeah. So what is the diagnosis now? After seeing this X-ray, this pancreatitis, hepatitis, whatever. Obviously.
Tuberculosis could be one possibility.
Okay. Anything else?
Tuberculosis itself cause hepatitis, or the drug given will cause hepatitis?
What?
After the drug toxicity, it can cause, but tuberculosis itself, can present as hepatomegaly, not as hepatitis with jaundice. Unless lymph node is pressing on the.
Leptospirosis.
What?
Leptospirosis.
Lepto. Okay, lepto, we haven't done.
Thyroid, PTH.
Why that, sir?
Any other infection, Dr. Shailesh? If you suspect.
Brucella.
Brucella, I told, sir, it was negative.
Chest and hepatic involvement with anemia.
Mycoplasma.
Yeah, gastric aspirate, actually, we have sent, it was negative, CBNAT negative. So our, should I just show our, what was our differential diagnosis? That time our, on day 1, day 2, her differential diagnosis was acute pancreatitis with multi-organ involvement, or any hepatitis with acute cholangitis with multi-organ involvement. So I'll just show her further progress. So we started on antibiotics. We kept her nil by mouth with IV fluids, and we took a pediatric gastroenterologist opinion. So further progression, her X-ray day 3, her oxygen requirement is increased on till day 3 with this X-ray and ABG. So what is your interpretation on this X-ray and ABG?
Oxygen or room air?
This was actually 50% FiO2. This ABG was on the 50% FiO2 with HFNC basically.
So there is hypoxia. There is definitely hypoxia with respiratory alkalosis.
And
we have lactates. Okay.
Okay.
Okay, so this looks like an case of acute pancreatitis with and going into ARDS.
ARDS.
So where the oxygen requirement is increasing, the PF ratio is decreasing.
Infection.
Okay, so what are your thoughts actually, sir, or what you else, anything you want to do at this point of time?
So if it is acute pancreatitis, fluid management should be sufficient with
Acute
proper.
pancreatitis, they would have done some other investigation like amylase, and also they would have done ultrasound. They haven't done all these things.
Yeah, that is done.
Amylase lipase was done.
Yeah, amylase lipase already
So-
done, sir. So any
We have to give hemodynamic support to this child. Fluid management should suffice with proper
MOHS should be
with
managed.
proper
Supportive management.
respiratory care, respiratory supports will require.
Yes. So we started on HFNC 0.5 liter FiO2 with 30 liter minute flow. So we have done imaging also. So this was the CT chest and abdomen, which shows that she has findings suggestive of pulmonary edema and with subsegmental collapse of both the lower limbs, and ground glass opacity is very infective with ARDS. This was the HRCT. And CT abdomen suggestive of acute edematous interstitial pancreatitis with hepatitis and moderate ascites. So what do you take on this? What else investigations wise you want further? Sorry. Would like to proceed further investigations, or you like to wait? What you would like to do with this at this point of it, with worsening lung and with this pancreatitis, hepatitis, or any further investigations? Or what your thought at this point of view? Any, if you are sticking with your previous differential diagnosis, or you want to add anything?
IVIG or prednisolone.
Regarding what basis you want to give, sir, with the prednisolone? Should I show the investigation chart in this last 3 days?
Yeah, sure.
Yeah. So this is the investigation progress. This is on admission next day, and this is on the 3rd day when she got deteriorated. So anything?
Liver enzymes are increasing. And pancreatitis pancreatic enzymes are decreasing. CRP.
So both amylase and lipase levels have decreased.
Yes, I have. Yeah, sure.
Yeah, the bilirubin is increasing. Hepatic parameters are worsening.
Hepatic encephalopathy issue is increasing.
So anything else you want to do at this point of, because she has worsening lungs, she has a worsening liver, any further investigations, or you want to wait, or you want to just continue the same treatment?
Considering two serosal layers involved.
Baldev sir.
Continue with the supportive management.
Okay.
We'll wait and watch for improvement.
But her lung is already worsening.
Yeah.
So we need to intervene, or we need to rethink again, right?
Baldev sir, you can have your comment, please.
Yeah, I think I want to make it very small comment. Probably it is not pancreatitis. Probably it is not even the lung infiltrates. But the point is multi-system involvement. So whatever disease we can try to understand that it is involving the multiple organs, multi-systems. Second thing, I think fever and all CBC picture, not yes, it is inflammation, but probably not the infection. And if it is not infection, because looking at the acute phase reactants and other things, even blood culture, then probably it is a non-infective inflammatory condition. If it is not infective inflammatory condition involving multiple systems, then I think it should be some immune mechanism. If we understand the immune mechanism, probably rather than these even others, following some viral or other things, I think it should be autoimmune. So whatever the disease, probably we can try to understand that what is the autoimmune disorder. Autoimmune disorder may be following even some infections, viral or something, or even the body itself has created the antibodies against these very specific antigen. Even the history of 1 month back, similar problem, again probably favors that something was going on. This is just, I will say, small comment, then we can further think that what disorder can be there.
Yeah. So, sir correctly said. So, I'll just summarize this. This female child abdominal with persistent abdominal pain, nausea, vomiting, for fever for 10 days, with persistent anemia, thrombocytopenia, leukopenia, with direct hyperbilirubinemia, with acute intestinal pancreatitis, viral markers, tropical fever workup negative, blood culture negative, with normal serum procalcitonin level, and with worsening lungs. So, what is your take now? Or you want to, what if at all you want to investigate, what are the further investigations you would like to do? Or what you are thinking at this point of time?
Yeah, as Baldev sir said, we'll have to rule out autoimmune cause of this condition.
Okay, so what do you want to do? Rule out autoimmune. What do you want to do with this? How you will rule out actually? What you will send? What your next step?
Sure.
Any investigations you would like to do, or to rule out is autoimmune?
He's giving you a clue. Will you like to do some autoimmune markers? That's what she wants you to know.
Yes, sir.
We're not sure about it.
Okay, so just like that, we are also thinking, sir, if at all anything, what we will do. So what we thought is adolescent.
Disorder.
Yeah. So no infection, doesn't look infectious, multi-system involvement.
Good multi-system involvement.
Yeah.
SCID.
Two important points she has mentioned.
Yeah, and clinical and laboratory worsening. So actually, this was the third day she was worsening in front of us, and we actually needed one quick investigation so that we can confirm our diagnosis. So anything that come quick, we can send. right at this point of time, just to confirm her thing.
Female child, sir. Female child with serosal
Female.
involvement. Leukopenia.
DSDNA.
Yes, sir.
DNA, DSDNA.
But it is not quick now. It will take DSDNA. It will take 3 days. ANA it will take 48 hours. So you want to wait till 48 hours to come the reports, or you want to do anything else? Just you are correctly saying, but I'm just.
I think if you have the readings, you can put the ESR as CRP.
Yeah, ESR was 35, sir, and CRP was,
CRP was not yet
normal. 9, 10. It 6 was normal. So should I
think, is it any important?
Ferritin.
Yeah. Okay. Yeah. Ferritin.
Ferritin levels.
Yeah. I'll just should I show the reports what we have actually seen? Anything else apart from ferritin you want? Ferritin is correct.
D-dimer.
Okay, D-dimer we have.
Triglyceride.
Okay, triglyceride. So what you are thinking with this ferritin and triglyceride? And
is there any
secondary HLH?
Okay, because of secondary HLH because of what? Or
viral.
Because of post-viral infection or
post-viral.
Or apart from that, anything else, sir? Okay, I'll just show this. Okay, you are right only, sir. So it was actually C3C4 what we have done. Actually, it was quick, cheapest, and because worsening. So we have sent this, and it both came low. So apart from that, again with this also we have sent whatever the investigation you said. It was ANA. It came after 48 hours of the C3C4 report. So, so is it significant, sir?
Yeah, definitely.
Yes.
Definitely significant. Okay, so even ferritin was high, so fibrinogen was low, triglycerides with the higher side. So definitely, so what is your thinking? Anything like definitely, if she is having.
What do you mean?
Yeah. So this is the ANA blot. ANA blot DSDNA was positive. So definitely diagnosis was SLE with actually MAS, and which causes is pancreatitis and hepatitis and ARDS. Yeah. So just 2 things. This is newer classification of SLE. Show with this EULAR classification, she had a fever, leukopenia, thrombocytopenia, and low C3C4 with anti-DSDNA antibody positive. The total score more than 10 was significant. Our patient has 16. And so we actually gave this, we took rheumatologist opinion. He advised hydrocod, but patient was significantly worsening in front of us. We gave methylprednisolone, we gave cyclophosphamide, and she, with HCQ, she is now in remission. It's almost 5 months after this. This is the left. She was at time of discharge, and she is now like this, with her lungs improved over the period. Just one slide, sir. This is like review of literature. It showed that pancreatitis is rare in pediatric SLE patients, and out of that, only 127 pediatric patients reported in last 30 years, and there is mortality rate is very high. And in this 52% patients with pancreatitis in this literature had MAS at the same time. And this occurrence of pancreatitis and MAS in SLE is not an accident. Actually, it comes along. This pancreatitis may be the target organ of this MAS in patients with SLE. And there has been no large sample size survey in the incidence of pancreatitis in children with SLE. This may be because the incidence of pancreatitis in SLE might be underestimated. And these are the reports. Actually, this till now 32 patients reported all over world. In that, 3 case reports are from India. Thank you, sir.
Excellent case by Dr. Snehal Patil, madam, and similarly, Team Amravati have cracking in between when they ask for the ANA case, and madam have given the right right clue कि any adolescent girls with multisystemic involvement, we have to suspect autoimmune disorder when patient is not fitting with our clinical progress. I request our Dr. Srinivas sir and Dr. Baldev Prajapati sir to have their expert comment.
Yeah, I have been trying to give a lot of clues for to this thing, no, repeatedly mentioning about the female child, and I have been giving
Yes,
hint about the autoimmune thing repeatedly, thinking that you will be. Anyhow, whenever a child is having multi-system disorder in a female child occurring at that age with anemia, etc., we have multi-system involvement. We have to think of that possibility. So, of course, what is important is the child has recovered completely and looking very healthy. That is very great. Yeah.
That's incredible. Such a rare case and with a good outcome.
And Dr. Baldev?
I think the important message which we can learn from these other cases, that from day one, nobody knows that what problem is developing. But the very important point that keep the eyes open and even take their history repeatedly, put the points on the paper, and see that how the case is evolving. At this one juncture, once you feel that whatever disease process, but it is involving the multiple systems, and suppose it is fever, but you don't have the evidence of infection, it becomes a very strong point to consider it's a non-infective inflammatory condition. And with that reason, if you consider that various disorders we have to keep in mind, then autoimmune, any immune disorder becomes a strong point. But the autoimmune disorders are common. And with this given scenario, as already sir was also mentioned, but we were restricted to speak, that the adolescent girl, even I hope that the blood pressure might have been measured. Many a times hypertension may be the early markers to suspect even the renal illuminated SLE. Even the just routine investigations, if we see that in spite of this high fever and the evidence of the inflammation, total count is not rise or even total count is low. I think again that favors this very specifically among the autoimmune, the SLE. Similarly, in most of the autoimmune disorders, there is thrombocytosis. In SLE, usually we get the thrombocytopenia. And if you look at the ESR and CRP, that ESR is rising, but CRP is remaining normal or going down. I think that even from the routine investigations, when you are thinking for the immune disorder, it becomes quite obvious that probably it should be the SLE, and that to the adolescent girl, the way which we have described. Check the urine, by chance if it shows the hematuria or even the albuminuria, which is very common in the environment. And I think rest of the things on skin and other sites we have to keep in mind. But of course, we understand that these disorders are diagnosed at the due course of time when they are evolved and it becomes obvious. But I'm sure that if we keep this our history, examination, routine investigations, most of the times we are able to reach in the due course of time, we'll get the diagnosis. Thank you very much. At least I think I should express our gratitude to office bearers for inviting me and giving this opportunity. Thanks a lot.
Same from my side also, it's always an educative thing, and Dr. Mahate knows how a good student I am, listening to almost each and every day some lessons. So each case gives us a new insight and new information. So we definitely learn every day. Thank you so much.
And I think one more point, in such a case when it is diagnosed, suppose immune disorder, juvenile neuropathic or anything, and in that case when the ESR starts to go down and CRP is increasing, it makes a very clear that the complication of macrophage activation syndrome or even some infection.
In
So
such
I think
an age with a girl, always
clues.
think of autoimmune hepatitis as a possibility. And of course, SLE should be there in the mind. That is very important. Because it's not a typical acute hepatitis, which, the way the child is presented. So, multi-system organ involvement in a female child at that age with this thing, we must always consider open mind with autoimmune condition, because we have seen few number of cases of autoimmune hepatitis. Thank you.
Any
Thank
comments
you.
from Mohit sir?
Dr.
No,
Makesh, your comments?
I was just wondering on these platforms, if there are 100 cases presented so far, at least 10 have been SLE, and all of them have been different. We have seen the cases right from age of 4 or 5 years till 15 to 18 years,
SLE
and
is,
all of them have come up with a different kind of phase. That's what is SLE. So when you have a fever without any definitive diagnosis, you're looking at it as infective or inflammatory. When it progresses to multi-system and further, very likely inflammatory, less likely to be infective. With that, as Prajapati sir said, ESR high and CRP low, move on to SLE. That comes with cytopenia, move on to. But all this wisdom comes at the end of the case. Believe me, it's not that simple. Especially with every case adding some new flavor. Here, pancreatitis. Honestly, I myself had not heard of pancreatitis coming in SLE. That was a bit unusual. Again, child of SLE moving into ARDS. I have seen somebody with hypertensive cardiac failure and coming with pulmonary edema and ultimately succumbing to that. So those kind of variations we have seen. We have seen encephalopathy. We have seen vasculitis in multiple organs. But pancreatitis to me has been a masquerader. But mind you, amylase lipase is never always pancreatitis. We have seen even a gangrene bowel giving rise to amylase lipase. We have seen plain hepatitis coming as amylase lipase. So that's just one kind of a thing. Secondly, your HGOT-PT relation, if you see, OT has been 4 times more than PT, which is a non-hepatotropic marker, which again suggests it's a generalized systemic disorder, not a primary hepatitis. So there are multiple markers. Summing up all the dots, perhaps multi-system inflammatory in a 13-year girl child with a recurrent episodes. I think you had some clue at least by 4th or 5th slide. I won't say first slide, definitely. It's too ambitious to diagnose on first visit. But I distinctly recall one of those cases when Dr. Ambedkar sir used to visit my hospital, and we used to have once in 15 days clinic. I presented a similar case, which had come a 6-year-old boy who came with like a respiratory failure, and he turned out to be pulmonary edema. And sir on 3rd slide said this is SLE. And I think he has got an amazing sixth sense, which is having a lot of logical background. So there are a few clues which need to be taken. But that child had an ESR of 120 and CRP, we never, it's almost 15 years ago. We never used to do CRP then. Nowadays, all those markers and ferritin and everything has made it a bit more simple. But then there are definite some clinical clues in such cases. Amazing. Both cases have been a great learning experience. The first case, I have not seen JMM coming at that age. But that child had a hemoglobin of 7.2, still very stable, telling me that hemoglobin was existing for quite a long time. He had a massive hepatosplenomegaly, which won't come in a 1 or 2 days disease. So that was also happening for a long time. So you're dealing with some chronic disorder, not an acute disorder. That is a clear clue. And then that kind of a massive hepatosplenomegaly, somebody was saying it is a hemolytic anemia. Hemolytic anemia with 7.2 hemoglobin at that age would have crashed. That kind of a large spleen and liver coming in 2 days of sepsis is least likely. So we could go with a negative kind of a thinking, rule out this, rule out this, rule out this, and then perhaps you could have landed up on a malignancy. So there's some kind of a indirect clues. That's how I would go about it. But I'm sure both cases were extremely interesting learning experiences. And we never miss this particular case program.
You please publish this in
experience.
Indian Pediatrics and this thing, because others also should know.
Yeah,
so we
yeah.
are lucky to have listened to you people.
Dr.
But
Ramakant
unless it's
is there.
published, others will not know that.
Dr. Ramakant is there. Somebody should compile all these cases. It's going to be a great, another grand round.
Just
maybe
like
Dr.
Ambedkar's
Ambedkar's
book,
opinion with that.
The cases you should bring it out. Yeah.
Yeah.
We should
Thank you.
definitely do that.
Very good. Thank you so much.
Thank you.
Thank you, sir. Thank you.
Friday, sir.
Yeah, thank you, our teachers of teacher, Dr. Srinivasan sir and Baldev Prajapati sir, for their excellent comment. I just want to know from Dr. Snehal madam, whether they are also suspect autoimmune hepatitis in this patient, because ANMA positive with the autoimmune hepatitis. So if you done other marker to rule out whether it is associated autoimmune hepatitis or just SLE causing this, all this picture.
Yes, sir. Actually, this all looks SLE causing this, because this hepatitis never worsened. Actually, she had cholestasis, but never worsened. INR was almost stable till she was there. So it's mostly SLE causing this hepatitis, and basically macrophage activation syndrome, and this causing pancreatitis, like that. Just per se hepatitis, autoimmune hepatitis is less likely.
Okay. Thank you.
Kindly see these cases are being published because each one of them are very instructive, and we can bring it out as a booklet for younger generations to know. Thank you so much.
Thank you, sir. Thank you, both experts. Thank you, the talented presenters. Were excellent cases, and you have dealt with it very nicely and with a very good outcome. And of course, both
Dr.
the
Pramod is not there. Pramod Kulkarni's and Anjali's. We would like to have their comments.
Pramod, so you want to have any?
No, sir,
Dr.
nothing more
Kulkarni,
to
sir.
say. Nothing more to say. You being there. Thank you so
Oh,
much.
no. No, yeah, because your words of wisdom are always wanted by me and Bala. We wait for your comments. Yeah. Thank you, sir.
Thank you.
Thank you, all the audience. And I think the comments from Prajapati sir and Srinivasan sir and the enthusiasm that they have, it's really infectious because the way they are into the case, and again, they're consistently upgrading themselves still.
But I was liking the way you were smiling whenever I was trying to give a clue to these people. Yeah, yeah. Thank you.
That's so much to learn from you, sir. So thank you, everybody. And let's move for one
Examiners
more.
many times give clues for
Yes,
their, when they are presenting cases. Some examiners are very kind enough to give some clues, but they should try to pick it up and then try to.
Yes.
Thank you. Even my metamyelomonocytic leukemia, I was mentioning repeatedly that particular words.
Yes.
Maturation arrest and this thing. Yeah. Thank you, sir. Very good.
Good night.
Thank you.
Thank you. Thank you.
Good night.
Good night.
Good night. Thank you, everybody.